There's an outdated saying that the standard of care is to miss aortic dissection on the initial ED visit. While we have made significant improvement in diagnosis and treatment, we still miss 1 in 6. So how do we continue to debunk this old saying? And how do we do better as emergency medicine physicians? Hello, everyone. I'm Dr. Kenny Chang, academic vice chair at VHS EM residency in Las Vegas. Today, I'll walk you through how to recognize aortic dissection in seconds. Here are just some examples of how aortic dissections might present and how one might encounter them as a clinician. Chest pain, diaphoresis, looks sick. Everything in you wants to call this a STEMI. What about the patient with radiating flank pain without chest pain that you decide to work up for urolithiasis? Patients then sent to the waiting room, pending the CT scan. What about the patient who had chest pain 2 days ago? It radiated between the shoulder blades. It was bad then, but symptoms are now improved. So the problem is, most of us are trained to approach chest pain in a standardized way. EKG, troponin, and that works for ACS. But aortic dissection does not follow that script. Because in real life, when a patient rolls in, clutching their chest, diaphoretic, maybe hypotensive or hypertensive, you're not always thinking about the aorta as the first thing. Because the presentation is inconsistent, it can also mimic many other pathologies, including but not limited to things like pulmonary embolism, musculoskeletal back pain, urolithiasis, and biliary colic, just for example. So what is an aortic dissection? It's a tear in the inner layer of the aorta. Blood enters the wall, creating a false lumen. Now you essentially have 2 channels of flow in the main arterial supply for your entire body, and that can disrupt perfusion. 2 main types. Type A involves the ascending aorta. That's a surgical emergency. Type B, these can be managed medically first, although surgical care is oftentimes considered afterwards. So your CT surgeon should still be consulted. And the reason why this matters is because this can kill patients fast. Rupture, cardiac tamponade, stroke. This is a time-sensitive diagnosis. So each hour that passes from the onset of symptoms is an estimated 1 to 2% increase in mortality. Let's think about 3 red flags as your recognition framework. Number 1, it's very important to ask about the pain to hone in on your diagnosis. Is it sudden onset? Is it maximal onset? Most commonly, patients may report sharp, but the highest likelihood of those that do have aortic dissections will describe it as a tearing sensation or a ripping sensation. Another question to ask, does it migrate to your back or your abdomen? I always tell our learners, think about aortic dissection as a subarachnoid of the torso. Number 2, pulse perfusion deficits. Keep in mind that these are often late findings. Things like asymmetric pulses, a blood pressure difference between arms, limb ischemia. And number 3, neurological atypical features. Things that don't quite fit a clean ACS picture. Things like syncope, stroke-like symptoms, voice hoarseness, abdominal pain. Think about it as chest pain plus 1, which is basically chest pain plus any abnormal perfusion or neurological finding. In that case, think dissection. Here's why this matters. The danger isn't just missing the aortic dissection, it's also treating it wrong. If you assume ACS, you will likely initiate heparin, antiplatelets, thrombolytics, and this can actually worsen bleeding and propagation of the dissection. So on your clinical shifts, if dissection is on your differential, you should pause before you anticoagulate. So here's how it plays out on your clinical shifts. You get a patient, chest pain, abdominal pain. Patient arrives and something feels off. So you say to yourself, and you also verbalize to your ED staff, I'm concerned about an aortic dissection. Here are your next steps. Number 1, the gold standard is to get that CTA, chest, abdomen, pelvis. And most importantly, make sure it's a specific one for the aorta, and it's not something like a CTA for a pulmonary embolism. Make sure to avoid the common pitfalls. A chest x-ray is not sufficient to rule out aortic dissection. The classic teaching of the widened mediastinum, loss of aortic knob is not enough. And POCUS, while it is advancing and specificity have been nearly 100%, it still lacks a sensitivity. And the D-dimer and the aortic dissection detection risk score is being used commonly by many clinicians, but it's still not externally validated. Your next goals here for management. Do not miss pain control, first of all. This is very important to control sympathetic stimulation. Your next goals are to reduce heart rate while maintaining a low to normal blood pressure. This reduces aortic flow acceleration, and this reduces the shear force on the intimal wall of the aortic dissection. Esmolol and beta blockers are often first line. Esmolol tends to have a short half-life. It's easily titratable, which makes it oftentimes preferred. So here are your 4 take-home clinical pearls. Number 1, not all chest pain is ACS, and not all aortic dissections present primarily with chest pain. Number 2, in aortic dissections, pulse deficits and neurosymptoms are red flags. Number 3, if you're thinking dissection, don't anticoagulate. Number 4, CTA is your standard diagnosis. To summarize, the EKG helps you find the MI, but aortic dissections reveal itself when the story doesn't fit. Recognizing that moment can save a life. While we may not be the ones to provide definitive or final care, what we do as emergency medicine physicians is crucial. We're the diagnosticians and we're the resuscitationists.